So MPN AML is an aggressive form of stem cell malignancy that evolves from an antecedent myeloproliferative neoplasm. And unfortunately, the median survival of patients with MPN-related AML, or MPN blast phase as it's also called, is on the order of 3 to 5 months. And induction chemotherapy alone doesn't significantly alter that unless it's followed with consolidation, hematopoietic stem cell transplantation. So the first, aspect of evaluating someone with MPN-related AML is whether they are a person who has the potential for cure versus not cure. So curative intent would be ultimately getting them to a transplant. Non-curative intent would be trying to extend a good quality of life with available agents. So for those patients who are transplant eligible, these are patients typically under the age of at least 75, if not 70, with a good functional status and lacking significant comorbidities. We typically use either induction chemotherapy followed by transplant with a matched unrelated or matched related donor, or even a haploidentical donor, or a hypomethylating agent, either with ruxolitinib, with Venetoclax, or even with an IDH inhibitor. I'm a definite proponent of clinical trial use. So if the clinical trial is available, I would encourage that, particularly if the patient is eligible, because most clinical trials will allow for patients to move on to transplant if they have clearance of their blasts. And that's typically a requisite, although I would say it's not clear from every study that one needs to be in an AML CR in order to enjoy the benefit of transplant. And the risk of transplant is significant, so one wants to optimize the patients for transplant. At our institution, we do try to reduce the blasts as much as possible. But that discussion of benefit to risk needs to be individualized in each case.